All right, dudes and dudettes. Welcome to the voiceover presentation of the exciting world of GI medications. I know you're excited. I'm excited. Let's get started. So let's talk about the causes of GI disorders. Some of those underlying causes include just dietary excess, taking in too many calories. Stress, it's always a big one, especially when we're talking about ulcerations, but even GERD. Hiatal hernia can occur and cause some GI disorders. Some of you saw that in clinical. Hiatal hernia causing GERD and esophagitis. GERD itself, just esophageal reflux. Adverse drug effects, we've talked a lot about that already. And peptic ulcer disease. All right, GERD, gastroesophageal reflux disease. What is it? It's backflow of gastric contents into the esophagus. It can be caused by an incompetent sphincter, pyloric stenosis, motility disorder, obesity can sometimes cause it. There's different things. Signs and symptoms, dyspepsia, pyrosis, regurgitation. Those are the most common signs and symptoms that people report. And then peptic ulcer disease. This is the erosion in the lining of the stomach. And sometimes those adjacent areas of the GI tract, like the duodenum. The signs and symptoms, that gnawing, burning pain. It's relieved a lot of times by eating, but worsens after the meal. So pain after the meal is the number one sign. So again, eating itself a lot of times will relieve it, but then after that meal, you'll get pain. Different causes of this. H. pylori bacteria has been noted to be a cause. Excessive acid secretion from the stomach, stress, different things like that. And then, of course, medications, which we've talked about. NSAIDs, aspirin, glucocorticoids, and multiple others. So let's get into some of the meds that we use to treat these. Histamine 2 antagonist, very common medication. You can get these now over the counter. Famotidine, just a fancy word for Pepcid. Cimetidine, that's your Tagamet. There's also ranitidine, that's your Zantac. Again, very common medications. The way these work is they block H2 receptors in the stomach. And H2 receptors in the stomach are responsible for part of that process that releases hydrochloric acid. They don't only work in the stomach, they actually work on H2 receptors all over, so that you will sometimes see these utilized in allergic reactions. We know we commonly use H1 blockers. We already talked about H1 blockers, diphenhydramine being the principal one there, as far as especially a true allergic reaction is concerned. We use diphenhydramine for that. It's an H1 blocker, but you will see H2 blockers used during allergic reactions as well. So it's not like they're only going to block those in the parietal cells, although your book will tell you that is the case. I'm telling you right now, you're going to see these utilized a lot during those types of reactions. I was thrown for it the first time I saw it because, the doc ordered 25 of Benadryl. No, I think it was 50 of Benadryl IV, 20 of famotidine IV. Ugh, it was something like that. And I'm like, what are we giving him Pepcid for? It doesn't make any sense. It was before I fully understood what was going on there. But mostly we're using these for GERD, peptic ulcer disease, and then we also use them for prophylaxis. So if you've probably seen this already in clinical a couple times, where a patient is on an H2 blocker or a PPI, which we'll talk about PPIs here in a minute, but they're like, I don't have GERD, I don't have ulcers. But we discuss about how actually it's prophylaxis for those stress-induced ulcers in patients that are hospitalized. So when you're hospitalized, you are under stress. Your body's under stress from the illness. A lot of times you're under stress just from being in that environment. So the hospitalized patients they found are at a higher or increased risk of ulceration and GERD and things like that. So they give these commonly to hospitalized patients as prophylaxis. They a lot of times don't go home on them. They just do them while they're there in the hospital. Although they may go home. I'm not going to say you won't see that. But those are the most common indications. And again, the action, it blocks those H2 receptors, which are responsible for part of the process that gets that hydrochloric acid out of there. Okay, adverse effects, GI distress, GI effects, that's most common. Some people will report loose stools. Some people may even report constipation. Everyone kind of responds to these a little bit differently, but those are the more common effects that you see with these. It's GI distress because we're affecting GI. We're also affecting histamine, and if we go back to our H1 blockers, those would cause some CNS effects like fatigue, tiredness, lethargy. Some people may even complain of a headache with these a little bit, but they may get those same CNS effects, fatigue, lethargy. Be careful in people with hepatic or renal dysfunction. Interaction, it actually can slow the metabolism of a lot of different drugs. There's nothing like just straight up like this is contraindicated with this medication, but just realize this can potentially slow the metabolism of some drugs. Patient teaching, again, take as directed. Avoid foods and beverages that cause irritation. Stop smoking. Smoking increases the risk of these GI problems. And then separate from other antacids by 1 hour. And then these are over-the-counter medicines. People commonly use these for heartburn, for self-treatment, and that's fine, but they really shouldn't use them for longer than 2 weeks. If you need them for longer than 2 weeks, you need to go to your doctor to get checked out because there may be something more serious going on. Not to say that people aren't on these for long term, they are, but again, those people are being followed by a doctor. Antacids, another very, very common medicine that people take on their own for self-treatment. And there's nothing wrong with that, again, as long as they're doing it appropriately and not for long periods of time. There's different types of antacids. That first one, magnesium hydroxide, that's milk of magnesia. Calcium carbonate is your Tums. And you got sodium bicarb. Some people even still use that. So, some Arm & Hammer. People do use that. Action, it neutralizes stomach acid directly, right? It directly neutralizes that stomach acid. And are indications that heartburn or hyperacidity, relief of those symptoms associated with hyperacidity, the heartburn and all that. Adverse effects. Adverse effects on this is kind of funny. Some of these are more likely to cause diarrhea. Some of them are more likely to cause constipation. Magnesium, of course, milk of magnesia. We all know that as an antacid, but also commonly a stool or laxative. So that's going to potentially cause loose stools and diarrhea. Whereas like aluminum salts, which I didn't go over in that first slide, but aluminum hydroxide is another common antacid. I think it's called Amphigel or something like that. But anyways, it can cause constipation. There also could be electrolyte imbalances. I mean, think about this. We're giving them sodium, we're giving them calcium, magnesium. There's a potential there for electrolyte imbalances if we're not taking them appropriately, especially. And then rebound acidity. So if you take them for long periods of time and then stop, you end up with rebound acidity. Your body's going to react to that neutralization by just making more stomach acid, which can be a problem. Contraindicated in electrolyte imbalances. Be careful in people with renal impairment or GI obstruction. Interaction, they actually affect the absorption of a lot of other drugs, so it's really best to take these apart from other medications, and we'll talk about that with patient teaching. Patient teaching is really important with antacids. So take these about an hour or two apart from other drugs, again, because it can affect the absorption of many other drugs. It's probably best to take the other drugs first and then, wait about an hour and take these medications. Normally we take these with meals and at bedtime. Usually a lot of times people will take them a little bit before their meal at bedtime. Drink at least 2 ounces of water after taking. Avoid foods and beverages that cause irritation. And again, we'll just have to we can talk to them about the classic stuff like caffeine, spicy foods and some people's beans, but everyone's going to have their own little thing that can cause that irritation. So we'll kind of help them recognize those and see if we can help them with a plan to avoid those. Again, do not take longer than 2 weeks. Call your doc if you need them for that. And then stop smoking. Proton pump inhibitors. You're going to recognize these because they end in prazole, P-R-A-Z-O-L-E. So omeprazole, pantoprazole, there's others as well, esomeprazole, there's others. Again, common over-the-counter medicines. We can also give these, some of them IV, like pantoprazole is very common IV. What these do is they suppress the gastric acid secretion by inhibiting the enzyme that produces the gastric acid. So it just works on that enzyme that actually produces the gastric acid, helps inhibit that, thereby reducing gastric acid production. That makes sense. Indication, GERD, ulcerations, so gastric and duodenal ulcerations, and erosive esophagitis. Adverse effects. Some people may complain of a little bit of headache. The most common side effect, again, is GI distress. Some people may have a little bit of loose stool, a little nausea with these. And then there's some adverse effects, especially when you're taking them for long periods of time. Increased risk of osteoporosis, especially again in those that have been taking these for long periods of time, and especially in the elderly. And then C. diff is another potential adverse effect that they found associated with these. The theory there is that we are, by messing with the acidity level in the stomach, we can also mess with the normal flora in the GI, and for whatever reason, C. diff seems to thrive sometimes in certain individuals, especially those that have been taking these for long periods of time. So there's a risk there. So we just know to watch those for people that need these for long-term use. And we're going to be careful with people with long-term use. Certainly, people should not just self-prescribe these for long-term. If you need these for long-term, which many people do, and that's okay, they just need to be followed by a doctor. So, first off, they need to be checked out by the doc to see exactly what's going on, make sure that this is an appropriate treatment for them, and then continue to be followed because, there's some risks involved with long-term use. Interactions, digoxin, clopidogrel, aka Plavix, and some other drugs as well. Patient teaching. This doesn't provide immediate relief. It's more, it needs some time to work. You swallow the capsule whole. There are some that can be sprinkled, but you don't crush them. Take with 8 ounces of water at least an hour before a meal. You'll see some that will tell you at least 30 minutes, go by whatever the doctor and manufacturer recommendations are, but it's probably best an hour before the meal to allow them to fully start to, dissolve. Avoid foods and beverages that cause irritation. Do not take longer than 2 weeks without provider. And stop smoking. All right, let's talk about a GI protectant. This is for ulcerations, and what this does, sucralfate actually coats the ulcer. You'll see them used with duodenal ulcers. They protect that ulceration from further breakdown to promote healing. You'll see them used, again, duodenal ulcers, maybe even some gastric erosion. Adverse effects. So let's think about that for a second. We're kind of coating the GI tract. These can cause constipation. That's the most frequently seen adverse effect anyways. Just talked about adverse effects on the other page. Again, constipation. That's the most common. Contraindications: dysphagia and GI obstruction. Dysphagia because you would not want to accidentally aspirate this. We don't want to coat the lungs, right? We only want to coat the GI tract. So you would certainly not want to give this to somebody who's got dysphagia and risk of aspiration. And then GI obstruction makes sense because we don't want to cause further constipation. Be careful in people with renal failure, people that are pregnant or lactating. Interactions. It can interact with antacids, especially those aluminum salts antacids, because we can actually cause aluminum toxicity, which is interesting. And then it decreases the absorption of multiple drugs. So again, you need to take those other meds first and then follow that up, later with the sucralfate. Because think about it, we're just coating that lining of the GI tract, potentially causing those meds from being able to absorb appropriately. Patient teaching. Take exactly as ordered. Take your other medications first, usually. Separate these by about 2 hours. Takes about 4 to 8 weeks for ulcer healing. And then think about the biggest adverse effect, which is constipation. It's the most common one. So let's teach them about ways to avoid constipation. Increase water intake, increase fiber intake, increase activity, those types of things. Avoid foods and beverages that cause irritation, and stop smoking. All right, drugs affecting gastrointestinal motility. This is an area where nurses can make a huge difference. Because let's think about it. When you really got to go, but you can't go, you feel miserable. So if we can help them go, evacuate those bowels, they'll feel a lot better. Maintaining GI function. So what's some non-pharmacological measures that we can educate people on to help them maintain GI function? We all know high fiber diet, increase fluids, especially water, right? Don't increase fluids like tea and coffee so much. Increase more the fluid or water if possible. And then exercise. Yeah, get moving, get up, move. All right, some laxatives that we do use. Chemical stimulants. The common one here is bisacodyl, senna. You'll see those quite often. They irritate the lining of the GI tract and cause increased movement. So they irritate the GI tract. That is supposed to increase peristalsis, thereby increasing, eventually the bowel movement. Bulk. This is your psyllium polycarbophyll, also known as Metamucil and Fibercon. What these do is they help soften the fecal mass. They increase the bulk. So they increase the bulk of the stool, which helps by stimulating those stretch receptors. And then they also help pull some water in there to help soften the fecal mass and allow it to move. Osmotic. These draw water into the intestine. So It softens the stool again and increases the mass again. So this one just directly draws water into the intestine that will increase the mass of the stool and increase, loosen that up a little bit, help soften it. Your examples of these: polyethylene glycol, also known as Miralax, and mag citrate, also magnesium hydroxide or milk of magnesia is another one. At mag citrate, you'll see that used usually. I've only seen it used in certain circumstances. We'll a lot of times try maybe some softer things first. The mag citrate usually works pretty well, though. It comes in a little bottle. It looks like a Coke bottle. It's cherry or lime. I've never tasted it, but I can't imagine that it would matter which ones. They're probably both going to taste horrible. But a lot of times we'll drink half that bottle, give it some time. If that doesn't work, we'll down the other half. People that use that, it usually do pretty good. It usually works pretty well. And then lubricant, these just help the intestinal contents move more smoothly. This is docusate, sodium or colace, mineral oil. Docusate's probably the most common one that you've seen. You'll see almost anybody that's on an opioid have docusate along with it, just to kind of help that contents move along a little smoother. And that's how those work. And again, remember, the best way is to ultimately maintain GI function. So increase exercise, fluids, fiber, all of that. Indications, they're short-term relief of constipation. Here's the problem with them, especially in the elderly. For whatever reason, the elderly gets it in their head that they have to have a bowel movement every single day, and if they don't have one every day, they're constipated, so they'll start medicating themselves. As we get older, we know everything starts to slow down. They are definitely at higher risk for constipation. However, just because they've slowed down and maybe having a bowel movement every other day instead of every day, that's okay. If they think they need the Miralax every other day, eventually they will need the Miralax every other day, and then eventually they will need the Miralax every day, and it just is a terrible cycle. So we need to break them of that. Then we need to make sure they understand only take these for short-term relief of constipation. If you need them for longer than that, you need to be followed by a doctor. So that's one indication, short-term relief of constipation, most common one, right? Other indications: preventing straining when it's clinically undesirable. So people with cardiac conditions, some people that have just had surgery. There's others as well, but anytime that we don't want them to be to strain, maybe they just had rectal surgery, very common for them to want to use these. Evacuate the bowel for diagnostic procedures. So, colonoscopy is probably the most common one we think about with this. You'll take Go Lightly, which makes you do anything but go lightly, right? It just makes you evacuate everything there. But we want that bowel to be nice and clean for when the camera goes there. There's nothing in the way. So again, evacuate the bowel for diagnostic procedures. And then removal of toxins. We sometimes use laxatives to help us get rid of toxins. K-exolate is one. Lactulose, right? Lactulose we use for ammonia to help us get rid of ammonia. K-exolate for like potassium. So there's reasons sometimes we take these laxatives just to try to, when we have toxic levels of certain elements in our body, it will help us or get rid of those. Adverse effects, well, it's obvious. Diarrhea, right? Diarrhea, if we're giving it for constipation, the likelihood of having it, too much loose stool is possible. Probably the number one adverse effect, though, is abdominal cramping. These commonly cause abdominal cramping, especially the ones that, like the osmotics, those polyethylene glycol, which is your Miralax or Go Lightly, magnesium hydroxide. But bisacodyl can too, no doubt about that. And even psyllium, I'm not going to say docusate sodium wouldn't either. They all can, but I've certainly seen the polyethylene glycol and the mag citrate and those types cause that abdominal cramping. But they all can, potentially. And that's probably the most common side effect. And some people will complain of a little nausea. Now, some other adverse effects that we need to be careful with: electrolyte imbalance, right? Because if we're causing too much stool to be released and they start having loose stools and diarrhea, we can certainly cause some electrolyte imbalances there. And then dehydration, of course, that way as well. And then we talked about it already, but dependency. So there is potential for some cathartic dependency on these medicines, especially in the elderly. You'll see that quite often. Contraindications: acute abdominal disorders, fecal impaction, bowel obstruction. You really wouldn't want to give these to anyone with ulcerative colitis or diverticulitis. However, sometimes they will use the bulk laxatives in diverticulitis, and there's different phases there of the diverticulitis too, but for the most part we try to avoid these. Caution in coronary artery disease, again, because we potentially could cause some electrolyte imbalances, potentially cause some problems there. And then interactions, they can interfere with the absorption of other drugs. Patient teaching: take as directed, avoid prolonged use, may cause dehydration. So we're going to, again, educate them on ways to avoid constipation. So intake high fiber foods, water, exercise daily. All right, stimulants. Metoclopramide stimulates the upper GI tract motility to increase GI activity and movement of the contents there, movement of the food through the stomach. It works also by blocking dopamine receptors in the CTZ, which we'll talk about the CTZ here in a minute, and that helps with nausea and vomiting. So you'll see this used for gastroparesis, GERD, but a lot of times where I've seen it most commonly used is in nausea and vomiting prevention. You'll see it sometimes postoperatively with chemo patients. And then I've also seen it used a lot with migraine patients as kind of a go-to nausea vomiting medication for them. Adverse effects. Okay, we're blocking dopamine. Anytime we're doing that, we have a potential for EPS, or extrapyramidal symptoms, which we talked about with antipsychotic medications. Most commonly, though, people complain of a little, again, I know we take it for nausea, but people will sometimes complain of nausea with this medicine. And then sedation and drowsiness. Contraindicated in GI obstruction, perforation, bleeding. Be careful in people with seizure disorders and depression. Interacts with alcohol and other CNS depressants. We have that increased risk of sedation. And then also can interact with digoxin. It may actually decrease the absorption of the digoxin. Patient teaching. Usually take this about 30 minutes before meals. Do not take more than prescribed. Avoid alcohol. Notify provider of any potential symptoms associated with EPS, so tremors, spasms, just movements that you're not able to control. Antidiarrheal medications. Bismuth is that Pepto-Bismol. Loperamide, that's Imodium. The diphenoxylate atropine, that's Lamodal. Anyways, these work by slowing the motility of the GI tract. Indication diarrhea. Again, we can get a lot of these over the counter, so we just got to be careful with overuse and abuse of these medicines as well. Adverse effects. Well, think about it. We're trying to slow everything down, so constipation. Also, probably going to cause some abdominal discomfort, nausea. There's a potential for toxic megacolon, and what that is, it's acute toxic colitis, and it causes dilation of the colon. It can be segmental, so just a small part, and it could be total. It's definitely an emergency situation. And then also black stools. Bismuth does cause black stools. It's common, so we'll just kind of warn them about that. Contraindicated in colitis, infectious diarrhea. So think about it. A lot of times diarrhea is infectious. It's really not a good idea to take an antidiarrheal for acute diarrhea. So if you've had diarrhea for the last couple of hours, just let that stuff ride. Let's better out than in, right? Keep it going. Get that stuff out of there. It's not really indicated for that. Be careful in children, especially any of them you'd be careful in children, but with the bismuth subsalicylate, again, that's a salicylate. We talked about those in Ray's syndrome. I know on Pepto-Bismol it tells you kids less than 12. I don't believe it's as associated as aspirin with Ray's syndrome, so maybe that's why they say 12. But anyways, just be really careful. They do have children's Pepto-Bismol, but if you look at that, it does not have the subsalicylate. I can't remember what it's got in it. I'll have to look at it. But anyways, there's that. Interactions. There's quite a few interactions, so just kind of keep an eye on those. Patient teaching. Take as directed. We'll tell them to drink small amounts of clear liquids. They want to stay hydrated, but you don't want to go drinking a ton at once. Just kind of keep hydrated by drinking little bits at a time. Avoid caffeine, right? Because all that's going to do is further exacerbate the diarrhea. And then let them know if they're taking the bismuth that it's probably going to turn their stool dark or black. So be careful. But just understand that's expected with that. Antiemetic agents, these are nausea and vomiting medications. So emesis, caused by stimulation of receptors in the CTZ, which is the chemoreceptor trigger zone, or also known as the vomiting center. That is in the medulla oblongata. Non-pharmacological measures. So if we can limit stimulation, like things that stimulate nausea and vomiting in people, and it's different. Different people have different things that cause nausea and vomiting. Certain smells, though, most of us, if we're smelling stool and vomit and things like that, that causes us to further want to puke, right? It's just the way it is, especially if we're already sick, or certain types of foods. Certain music like yawning. Most of us, when we hear something like that, usually want to just puke. But we'll just kind of assess the person, look for triggers, try to limit those as much as possible. Keep the room clean. If they have a bowel movement, we need to, evacuate that, appropriately, not try to leave that, clean them up. If they get some vomit on the, we're going to do that. We're going to clean people up appropriately, and we're going to clean up anything where they got the emesis. But just make sure to try to get rid of that. Try to get rid of those smells if you can. I've even they have these little machines that can filter the air, so to speak, and get rid of smells. A lot of hospitals have them. I've put those in places with people that were just having a hard time with emesis, and any little smell was causing. And let's face it, hospitals are full of smells. Maybe the guy, next to them is having C. diff, and it's kind of wafting over. I hate to be so graphic, but it's true. Maybe move them, or put one of those little machines in there to help them. Be careful with the stuff that just covers up the smell. Those sprays, that can actually be a trigger as well. I know I can't stand the smell of those things, especially if I'm already sick. Those things are horrible. So just covering up the smell a lot of times isn't appropriate. Not to say that it wouldn't work for everybody, but just be aware of that. Okay, promethazine, also known as Phenergan. You've probably heard this before. It's a very common medicine. We don't use it as common as we used to. We used to use it quite a bit. Don't get me wrong, it's still common. It absolutely is. But ondansetron has seemed to taken over as the go-to med, whereas promethazine back in the day was definitely the go-to med. Ondansetron has kind of taken over, and you'll see why here in a minute when we talk about both these meds. The action, again, blocks dopamine receptors in the CTZ. Indications, nausea, vomiting. There's others as well, though. We sometimes use this for sedation, like to help people. I've seen them use it for insomnia at times. That's an off-label use, but I've seen that used sometimes. But most commonly, it is nausea and vomiting. Adverse effects. This is absolutely going to cause sedation. So they should not drive. If you've given them promethazine, I need to say the proper name. They need to have a way home. So if you're in the ER, they're coming in for nausea and vomiting, and the doctor's like, let's give them some promethazine. Say, okay, do they have a ride home? Make sure that they have a way to get home, because otherwise you're going to be sitting on them for about 4 hours, because it's not appropriate to send them home after giving them this medication. It's to send them home unaccompanied by somebody. So sedation, again, very, very common. Some people complain of a little bit of a headache with this medicine. This absolutely is associated with our anticholinergic effects. Can't see, can't pee, can't spit, can't poop. Those are common with this. And then also hypotension. So just be aware if their blood pressure is under 100, let's maybe talk to the doc and make sure he's cool with giving that. A lot of times they're cool with it down to 90, but again, just be careful. Anytime it's under 100, I'm always thinking. I want to make sure I'm as safe as possible. And then, again, we're blocking dopamine. So we know there is a potential for EPS. So just be aware of those extrapyramidal symptoms. Contraindicated, coma, CNS depression. If they're already have CNS depression, not a good idea to continue to suppress that. Be careful in children, people with renal or hepatic dysfunction. Interactions, other CNS depressants, alcohol, opioids, what have you. It can interact again with other antihypertensives, which only makes sense because of the potential for hypotension. And then anticholinergic drugs, again, which makes sense because we don't want to continue to exacerbate those symptoms. All right, patient teaching with phenothiazines, again, it's going to cause sleepiness, so avoid activities that require alertness. Don't participate in anything that needs your full attention, like driving especially. Use sugarless gums, candies, ice chips for the dry mouth, because that's a very common side effect. And then, of course, we have the risk for EPS, so we'll let them know. If you notice any tremors, any uncontrolled movements, please alert us immediately. Another thing we need to think of with promethazine is it really should be given in a large vein. If we're given an IV, be careful because it can irritate the vessel. You don't want this infiltrating. So make sure it's a good IV in a large vein. Antihistamine, antiemetics, diphenhydramate, and meclizine. These a lot of times are over-the-counter medicines. These They are antihistamines, but they also work on the cholinergic receptors, which can decrease our nausea and vomiting. Can also help with motion sickness. So those are our indications: nausea, vomiting, motion sickness. Adverse effects, sedation, and anticholinergic effects. It's kind of what we're going for, but again, we can have the classic anticholinergic: can't see, can't pee, can't spit, can't poop. But we also can have some sedation with these, as we've talked about with antihistamines before. Be careful in the elderly and children. Again, remember, children can always have paradoxical effects with these types of medications. Anyone with a GU or GI disorder, we'd be careful with those anticholinergic effects. Interacts with other CNS depressants. Patient teaching. May cause sedation. Do not give to children under 2. Do not take with alcohol. Anticholinergic, antiemetic. These are the direct anticholinergics. Scopolamine. This is oftentimes a patch that's put behind the ear. It's usually good for about 72 hours. Interferes with the transmission of nerve impulses and the again, the CTZ. Prevents postoperative nausea, vomiting, prevention of motion sickness. Those are our indications. So again, nausea, vomiting, motion sickness. You'll see them used a lot postoperatively. You will also sometimes see this used in hospice to help with increased salivation, I'm sorry, not increased salivation so much as they're not able to control their salivation, so they're not, swallowing appropriately. They're just getting a buildup there, so they will use scopolamine to help dry that up a little bit and keep help them control that a little bit better. You'll also see atropine used for that as well, but just know that sometimes you'll see this used in hospice patients for that reason. Adverse effects, your classic anticholinergic effects. We already know what those are. So can't see, can't pee, can't spit, can't poop, drowsiness, all that. Contraindicated in glaucoma, caution. Anything that worsens those anticholinergic effects. BPH, right? That's the common one we think of with anticholinergics. Interacts with other anticholinergics, also because it can cause some of that drowsiness. CNS depressants, be careful there. Patient teaching, proper placement of the patch, how long to use it for. Again, it's going to potentially cause some sedation, so avoid alcohol. All right, ondansetron, this is our common one nowadays. You'll see this more prevalent than you will the promethazine. Again, promethazine is still used quite often, but ondansetron is a lot of times the one they go to first because it's just better tolerated. It doesn't have the sedation like promethazine does. It doesn't have the anticholinergic effects or hypotension. It's actually pretty well tolerated. The way this works is it blocks those serotonin receptors in the CTZ. And again, the indication, nausea and vomiting prevention. Our adverse effects are headache, dizziness, constipation. These are actually pretty well tolerated. Most people don't complain of adverse effects. If they do, again, a little bit of dizziness. So we will remind them, hey, please let us know if you need to get up so we can help you, because this can sometimes cause a little dizziness. Potential for constipation, so we'll warn them about that. Maybe tell them some ways to avoid constipation and headache. There is a potential for these to affect the QT interval. We will need to know that. That's really a caution. If they already have a prolonged QT interval, I've just seen them get more into this lately in the last few years. I know we've been doing EKGs on people that are going to need ondansetron, especially those that are going to need it for long term, or those that already have a history of cardiac problems before they give them the ondansetron. Let's just do a quick EKG and see what we're dealing with. So I would say, depending on that QT interval, it could certainly be a contraindication. It's more than just a caution. If they've had abdominal surgery, we'll kind of watch that. Interacts with alcohol and other CNS depressants, although this isn't as it's not going to cause sedation or quite to the extent of promethazine. There's still some chance there of causing some sedation, so just be aware of that. And in patient teaching, again, that may cause a little bit of dizziness. Some people may report a little bit of tiredness with it, but it's not nearly as common as promethazine. So check your protocols as far as whether you can let people go after they've had ondansetron or not, if you work in one of those acute care settings. I just talked about patient teaching, didn't I? Well, that was on the last page. All right, so cannabinoid antiemetics, dronabinol, I've given it once in my entire career. And I've known multiple people that have had it prescribed, but I'm not sure insurance is really into paying for it. I know it's super expensive, and I know of at least one. I know definitely one person who had it prescribed and just didn't buy it because it was so expensive. They just went other routes instead. Cannabis or marijuana is associated with decreased nausea, vomiting. I'm sure you've heard stories of people on chemotherapy or late stage cancer patients that use marijuana for those reasons. It actually helps stimulate eating, right? So it will help them eat and of course reduce nausea and vomiting, which also makes us want to eat a little bit more, right? If we're nauseous and vomiting, last thing we ever want to do is eat. Dronabinol it lacks the THC that's a lot of times associated with the more recreational effects of cannabinoids. But they believe that it's got the chemicals in it that helps with the nausea and vomiting. And that's our indication, nausea, vomiting, and it's usually severe. It's usually like chemo-induced or people with late-stage AIDS or things like that. It helps reduce nausea and vomiting, and also helps us gain our appetite. So people that are having anorexia secondary to these medical issues, they sometimes will use it for that. Adverse effects. Okay, so your book is going to tell you adverse effects that are commonly associated, as far as the FDA is concerned, with marijuana use. Dependency, hallucinations, euphoria, paranoia, amnesia. I've only given it once. I can't speak to anything. The guy, I think, got a little bit of relief and didn't complain of any adverse effects. But what we know about adverse effects is they certainly don't affect everybody the same way. What I will say is that's what your book's going to tell you: the dependency, the withdrawal, the hallucinations, euphoria, paranoia, amnesia, all these things that are associated a lot of times with marijuana use. Contraindicated in people with a history of substance abuse, psychiatric disorders. Watch out for cardiovascular disorders. There's a potential there for maybe some problems. What I can say is be careful, though, in people with seizures. If you have a history of seizures, these actually can decrease the seizure threshold. So we will be careful there. Interacts with other CNS depressants. Patient teaching. We'll teach them its potential to become habit forming. Don't share. If they do decide to take this routinely, it's best not to just stop abruptly. And then keep medications in a safe location.